All right, perfect. Welcome, everyone. Good afternoon. I am calling the Greater Boroughs Partnership for Health Advisory Board meeting to order. It is May 8th at 1:32. And quickly pursuant to the Chapter 2 of the Acts of 2025, an act extending certain COVID-19 measures adopted during the state of emergency and signed into law on May 28th, 2025, this meeting will be conducted via remote participation and no in-person attendance from the public will be permitted. So with that, I will just do a roll call of board members. So Westboro,
Jen here.
Southboro,
Taylor, present.
and then Northboro, Isabella, present. And also on this call, it's a very special call. We have Michaela, our shared service coordinator and regional epidemiologist. And then we have some folks from OLRH, so Jess and Mike, and then Manize from BME Strategies. So with that, I will pass it off to Manize.
Hello, everyone. It is so good to see you all again. I'm about to share my screen and see if this works. I'll probably go off camera as I'm presenting so that I don't have any technical difficulties. Let's see if this works. But today, if my screen loads, let's go. I will be sharing with you all your shared service arrangement level preliminary results from the Foundational Public Health Services Shared Services Review process. Before I dive into today's presentation, I want to really say thank you to each and every one of you for participating in this process, for taking the time to fill out these tools, and for working with me. It has been such a privilege to work with each of you, and I'm really looking forward to presenting this data back to you now so that you are all able to use it and to continue to further the important work you do for your communities. If at any point anyone has any questions, please feel free to come off mute and just ask them. This is a two-way street. I want this to be of value to you, but on today's agenda for this meeting, we'll be doing quick intros and I'll be reviewing the purpose of sharing all of this data with you. Then I'll really be diving into the presentation and discussion portion of the data, reviewing things like total spending on foundational public health services, reviewing 1 to 2 foundational areas or capabilities, and providing you with a data to action summary. I'll then be quickly previewing the data to action toolkit we have prepared for you to be able to use this data and next steps. Though I already know most of you, and I'm sure you're all familiar with each other, in the chat, please feel free to introduce yourself and which group or town you work with. And while you are doing that, I want to make a special shout out to Jess, your PC, and Mike Coughlin, who are both here in our meeting today. Would you like to introduce yourselves to the group, since I'm sure you don't regularly attend these SSA meetings?
Sure, happy to. Hi, everyone. I'm Jessica Furland, and I am a program coordinator in OLRH's Shared Services Unit. So there are 4 of us, 4 program coordinators, and we divide up sort of being a point person for SSAs, and so I am yours, and work closely with Isabella and Michaela to help your SSA to thrive. So I will pass it to Mike.
Thank you, Jess. Hi, everybody. My name is Mike Coughlin. I'm a post-retiree manager with OLRH. I guess I'm here officially kind of representing OLRH's leadership. So I'm glad to be here for that. But Maniza and Jess are much more engaged in this process on a day-to-day basis than I am. But I do have some background that might be useful as we go through the discussion. I'm a member of the Board of Health in Fall River, and I'm very jealous that you have an epidemiologist here who used to work for us. And nice to see Michaela again. I am for 15 years now, I've been a site visitor with FAB, the organization that drafted the Foundation of Public Health Services, and I might be able to throw in some comments about that as we go through it. And I'm a former local health director too, so I've been through a number of these things, and I'm glad to be here with you and meet you all, and say hi to Michaela again.
Thanks so much. And Manise, Northborough doesn't have the chat feature on Zoom, so
Thank you.
Yeah.
Didn't
I
realize
thought I
that.
was losing my ever-loving mind. I literally was like, this is it. This is now. It's happening. Thank you.
Thank you for helping me to realize that. Disregard what I said on the screen, and we will continue on. And thank you, Mike and Jess. All right. Before I jump into the purpose and goals of this presentation, I just want to take a second to remind everyone that the Foundational Public Health Services implementation is a stepwise process. The state truly knows it will take time for local public health in Massachusetts to build capacity to implement the foundational public health services and meet the foundational public health services as standards. So data from this FPHS Shared Services Review and the Special Commission on Local and Regional Public Health will inform the development of a timeline for the foundational public health services implementation. The purpose of today's presentation is really to provide you all with actionable insights that align with long-term capacity building goals, including identifying areas for increased shared services with an emphasis on enhancing foundational capabilities and meeting phase 1 of the performance standards. The goal of this presentation is to understand and to help you all understand how this preliminary data can guide your decisions and support each stage of foundational public health services planning and capacity building for this phased implementation. And again, at this point, I'm sure you're all very familiar with the foundational public health services, but as a reminder, and something that Mike alluded to, is that the foundational public health services framework was developed by FAB, or the Public Health Accreditation Board, in collaboration with this large network of public health experts across the country. And truly, these are the recommendations that have been adopted by Massachusetts in the Blueprint for Public Health Excellence and written into SAFE 2.0 legislation. The foundational public health services, as you can see on the screen, are made up of foundational areas and foundational capabilities. The foundational areas, which are in this light blue, are core public health programs and services necessary to keep communities healthy. And these foundational capabilities in the dark blue are skills and functions needed to support basic public health protections, programs, and services. Truly, throughout this presentation, you will see these same colors referred to when we're talking about the foundational areas and the foundational capabilities. The Massachusetts Department of Public Health is adopting this framework as envisioned in that 2019 Blueprint for Public Health Excellence report, and again, was written into SAFE 2.0 legislation. I want to remind everyone that local public health is not responsible for providing all of these services directly, but they are responsible for ensuring that all of these foundational public health services are available within your communities. I also want to take a moment to mention that the preliminary results that I will be sharing with you today are really not intended to be an evaluation of local public health or your SSA performance, but really these summary reports are intended to support you all with understanding your current services and resources, identifying opportunities to share these resources and improve service delivery, and obviously hopefully making data-driven decisions to address gaps and improve health equity overall. On this screen, you will see a table of contents. In today's meeting, we will not have time to review all of the preliminary the results available, but this table of contents provides an overview of what is available in this presentation that will be provided to you after this meeting. In today's time together, we will really be focusing on these first two items here at the top. We will review parts of the preliminary spending and foundational area and capability data and key takeaways of the data. Then we will do a quick introduction to the tools that will be available in the Data to Action Toolkit, which will be made available with the upcoming PHE work plan. We will not be able to review data interpretation guide or the data appendix during this meeting, but these will be available in this presentation as a resource for you. And both of these guides really outline key figures and additional data support to assist you in interpreting the data in here. Now we will move to the preliminary results presentation and discussion, where we will explore at the shared service arrangement level, overview of spending, service delivery, service sharing, and shared staff capacity and expertise. All of the results in this presentation will be presented at the shared service arrangement level. And as a reminder, these are preliminary results, and a full state level report will be available in the fall. On this slide, you will see an About the Data slide, which really emphasizes a few key points about the data that's included in these preliminary results, things like what's included and how totals were reported, etc. I'm going to skip over this for now, but if anyone has any specific questions about any of the data points we are discussing today, we can definitely come back to this. This slide provides even more about the data included in this presentation. An important note on the foundational public health services in Massachusetts, and information on your amazing group. On the right-hand side of the screen, you can see that your shared service arrangement, the Greater Boroughs Partnership for Health, is made up of 4 jurisdictions, and all 4 have completed data entry, meaning you've all completed both tools in this process, which is huge. On this slide, you will see total SSA spending key takeaways. This is a key takeaway slide for overall spending by your shared service arrangement in fiscal year 2024. As a note, as we review all of these slides together, you will see a key takeaway slide before each data visualization slide, which is truly meant to just summarize the data in the graphs and charts you see throughout this presentation. So as you can see on this slide, this shows total shared service arrangement spending and staff FTE in fiscal year 2024. The spending includes municipal spending and spending by the shared service arrangement. The total spending across the shared service arrangement in the last fiscal year was 1.24 million. 31.4% of this spending was from grant dollars, and the rest was from municipal funds. There were 8 grants total received in the last fiscal year by members of the shared service arrangement. And on this right-hand side, where you can see this regional versus not regional staff FTE, regional positions in this shared service arrangement include the following 5 categories. We have environmental health worker, who is a regional staff, a health educator, epidemiologist, and shared services coordinator. Before I move on to the next slide, does anybody have any questions?
I guess just one, I'm curious, the health educator, is that like a combination of positions? I'm not sure if we don't have one regionally.
Most likely when you are putting down your occupations, one of the roles that you have hired falls under this health educator position. So it could be something like a community health worker or a mass call 3 grant manager, things like, or like a grant management specialist. So oftentimes, due to the way that reporting is, we've had to put them under health educator. Because there is no category for like a grant specialist or a community organizer. But we can also review the data again together in more detail to see who fell under this section.
Okay, that sounds good. Thank you.
Of course. Great question. This next slide is about foundational public health services spending specifically. And since there's a lot less bullet points, I will slowly read this one for you. The key takeaways of the visual I'm about to show you will really talk about how across the shared service arrangement, 1.24 million, so all of what was spent on the foundational public health services in fiscal year 2024. The highest percentage of spending was on environmental public health. And across all of the foundational areas and capabilities, staff also spent the most time on environmental public health work. And this is exactly what this slide shows. So again, this is the total that was spent across the shared service arrangement on the foundational public health services, this 1.24 million. Over here on the right-hand side of the screen with the bar charts, you can see the percent total of the spending by foundational area and capability. So as you can see, environmental health is where the most money was spent across the SSA, and same with staff time. The most staff time was also spent on environmental public health, followed by organizational competencies, and so on and so forth. I will pause here for a quick second. Does anybody have any questions about this? Totally okay. If not, at this time, we can keep going. Now, this next section, capacity and expertise key takeaways. As you will all remember, in the service delivery tool, you were asked to indicate your staff's capacity and expertise for each service. Under each foundational area and capability, your shared services staff also indicated their capacity and expertise. This table in the gray summarizes the two highest foundational areas or capabilities for both shared service staff and all local public health entities or health departments. As you can see here, for your shared service staff, their highest capacity and expertise areas are chronic disease and injury prevention and communicable disease control. And for your health department staff, their highest capacity and expertise were for emergency preparedness and response and environmental public health. In terms of the lowest, you can see that for your shared staff's lowest capacity and expertise areas were in emergency preparedness and response and policy development and support. And this is kind of beautiful to see because you can see that we have a variation in the staff expertise and their capacity to do this kind of work. And that means it's a pretty balanced team right here. We don't have multiple people who can do all of the same things. We have people who can do all these different kinds of work in different foundational areas and capabilities, which is very complementary in terms of the work that can be done across the shared service arrangement. And then in terms of health departments, the lowest capacity and expertise were reported in areas such as access to and linkage with clinical care and maternal, child, and family health. And in terms of trends, this is what we're seeing across a lot of departments, our public health entities across the state. So this is pretty in line with a lot of other communities as well. Let's see. I am about to share with you 3 different charts that display capacity and expertise. This first chart here shows shared staff capacity and expertise for each foundational area and capability. This is just the zoomed out version, and this is the zoomed in version. So as you can see, for your shared staff, their highest capacity and expertise is in chronic disease and injury prevention, then communicable disease, communications, assessment and surveillance, organizational competencies, and so on and so forth. And then, as we discussed, the lowest areas of capacity and expertise are policy development and support in emergency preparedness and response. This second slide shows each health department's capacity and expertise for the foundational areas and capabilities. So again, the zoomed out version and then the zoomed in. So across the shared service arrangement. As you can see, emergency preparedness and response and environmental health are where there is the highest capacity and expertise, and then all the way at the bottom here are where the lowest capacity and expertise is in access to and linkage with clinical care and maternal, child, and family health. Now, this slide, which is a bunch of charts, displays both shared staff and local public health average capacity and expertise together for each foundational area and capability. These charts can show how shared staff can be used strategically based on shared staff capacity and expertise. So if you look here in the dark purple is shared staff, and in the orange circle is the local public health expertise and capacity. And so if you were to utilize just the information on these charts, you could say maybe we should increase our utilization of our shared services staff to do things like access to and linkage with clinical care or chronic disease and injury prevention work. And maybe we don't really need to utilize them as much for environmental public health, but there is still a need. But maybe we could even use them in maternal, child, and family health, and so on and so forth. And I know this is a lot of information, so I'll pause here. Does anybody have any questions about these charts? Totally okay, if not. Let me go back actually. Now that we've reviewed this extremely zoomed out view of the data, we're going to spend some more time drilling down into the data, focusing on specific foundational areas and capabilities. And I'm going to jump to a slide, not very elegantly. I'm going to have to just hit continue, continue, continue until I get there. I apologize. But if anyone sees anything that they're interested in and want me to stop on, I will take the time to review it with you. But the first one that I wanted to review with you all is about to pop up: environmental public health. So this, again, is the key takeaway slide for environmental public health, one of the areas where the majority of the communities in your group have quite high capacity and expertise. So as you can see from this detailed page, local public health entities dedicated 29.9 of total spending on environmental public health and 28.7 of staff working hours to environmental public health. Most local public health entities, as you can see from this FY24 capacity and expertise graphic, have higher capacity and expertise to do environmental public health work as compared to the shared staff. There we have on this side of the screen the service delivery fulfillment, and all of the data that is in here with all of these bright purple boxes where it says the local public health entity or the health department provided these services, the shared service arrangement provided these services, or an outside partner organization provided these services. With this data, there may be an opportunity to leverage existing capacity and expertise within the shared service arrangement, as local public health departments generally have a higher capacity and expertise. But if you look at these light purple sections right here where it says met community needs, it seems that for 4 of these activities, so things like develop a plan to promote environmental health, provide timely, scientifically accurate info on environmental health, implement population-based environmental programs and strategies, and inform, communicate, work cooperatively with others, it seems that a little bit less than half for most of these communities feel like their community's needs are not being met for these specific activities. So capacity building will be required to fully meet your community's needs in these activities. Before I go on to another foundational area or capability, I'm just going to pause. Does anybody have any questions here? No worries. If not, now I'm going to very not elegantly go back a few slides to show you access to and linkage with clinical care. We are almost there. Here we are. So again, this is the key takeaway slide for access to and linkage with clinical care. Looking at this specific area, again, this is the area where capacity and expertise was relatively low across the shared services arrangement. As you can see, local public health entities dedicated 1.4% of total spending and 1.3% of staff working hours to access to and linkage with clinical care. When you look at this chart on the left-hand side for FY24 sharing and service delivery fulfillment, it really looks like outside partners provided most of the services, while shared staff had moderate capacity and expertise to do this kind of work, and local public health entities had limited expertise and capacity to do this kind of work related to access to and linkage with clinical care. And if you look again at this last column here for met community needs, most health departments indicated that their community's needs for access to and linkage with clinical care were not met. So looking at this capacity and expertise graph here on the right-hand side, where it seems like shared staff definitely have moderate capacity and expertise as compared to local public health entities. Shared staff maybe should or could be utilized to support each of the health departments in this specific area. Partnership development with other partners that are also doing this work, including DPH trainings, could also be utilized to increase your shared service arrangements ability to help each community meet their needs. I'll pause one more time and just see if there are any questions on this one. And no worries, if not, I will then super elegantly continue forward somehow. I apologize for the clunkiness of all of this, but again, we have done this kind of breakdown for each foundational area and capability, so that is 13. And at the end of those 13 visualizations and key takeaways, we have provided you with this data to action summary. This slide summarizes opportunities to further strengthen or improve specific foundational areas and capabilities. You may choose to increase staff capacity and expertise to meet the performance standards through training and technical assistance with environmental, public health, and communicable disease, because these are the two foundational areas most aligned with the first version of the performance standards. You may also leverage existing capacity and expertise, where some municipalities have high capacity and expertise and other municipalities have low capacity and expertise in a given area. This could mean hosting staff training sessions by staff who have high expertise. And this also will align with existing sustainability objectives that encourage you and everyone to engage in internal resource sharing amongst each municipality in your shared service arrangement. You may also consider things like expanding service sharing where there is already high expertise, increasing staff capacity and expertise where current levels are lower, and building external partnerships where there are no services currently being provided. And as a next step, you can use the FPHS PHE Work Plan Crosswalk, a tool from the Data to Action Toolkit, to determine the actions your shared service arrangement would like to take based on all of these findings. This crosswalk will map each foundational area and capability to corresponding grantee work plan activities, helping you translate all of this data into action. Again, as a next step, we really want you all to be able to utilize this data and leverage these preliminary results in your work plans to be able to select your FY26 work plan activities. To do that, we have provided you with a data to action toolkit, which again will be made available alongside the rollout of the PHE work plan later this month. And again, the purpose of this toolkit was really designed to help each shared service arrangement utilize the data to inform decision making and planning. It's meant to provide actionable insights, support long-term capacity building, and support your work towards a phased implementation of the foundational public health services. This data to action toolkit includes these three tools you will see at the bottom of the screen. So an FPHS work plan crosswalk, a partner mapping template, and an FPHS discussion facilitation guide. Again, these are resources for you to use, and these are not requirements or things that you have to fill out. This is truly just so that you are able to continue utilizing this data going forward together as a shared service arrangement. In addition to this data to action toolkit, a support team is available for you for continued data support, which includes interpreting what this data means for your shared service arrangement. This team is comprised of OLRH, MHOA subject matter experts, and a BME strategies team member, aka me. And following this meeting, your shared services coordinator, Michaela, will receive an email from me with instructions for making requests for additional data analysis as well. And now to end the presentation, I'm just leaving you with some helpful resources if you would like to utilize them, things like the FAB FPHS website, a one-pager, Massachusetts examples and activities for all of these foundational public health services, the technical support request form, and just a reference to the blueprint for public health excellence. With that, does anybody have any questions? That was a lot of talking.
We will be getting a copy of this, correct?
That is correct.
Okay, thank you. Oops.
So we haven't obviously received the work plan for next year, but Jess or anyone on the call, will these be kind of incorporated into next year's work plan for us to choose between? Like be a little bit more foundational public health service based?
Yes, so the work plan will be similar format to last year, which is, you'll have options to choose from and be able to sort of customize. And Manise has provided us with input into some of those to make this work implemented into the work plan at the right rate. Right, so that we're not like skipping steps or like, missing anything. So, yes.
Perfect. Thank you.
Definitely a great question, Isabella. And again, it's not to add work to anybody's plate. It's truly just to show how the work you've already been doing as a shared service arrangement is very much in line with the foundational public health services. And now, since you've all went through this review together, you have data to use to do this planning for what you end up selecting for the next fiscal year. So hopefully these tools that we've created will make that process easier. Any other questions?
I think the only one I said in the beginning, I might reach out to you because we have a contract with Sam and VNA, and I don't think I saw regional nursing. I just saw the health educator. So that might just be a small error. Might have been on my part too, so.
Let me check one second.
Manise, it could be, so this group, it's a little different in that they don't have like one shared PHN on their municipal staff paid out of this grant. They contract with the VNA, so it's a little different, and we can talk on offline if that's helpful in terms of the data.
Most definitely. And I want this to be representative of your staff. So if you feel that that needs to be reported in a different way so that that nurse shows up the way that you believe their work is reflective of. So if they are a regional nurse providing regional nursing services, we want that to be shown. So we might just have to like press a different button
Okay.
in the cost tool, if anything, just to show that.
Perfect.
I feel like we just need a little bit of time to, interpret this. And then I think we'll probably have more questions and be able to meet about it would be helpful.
Most definitely. You have all of the time, and I want you to know that there is continued support for how to utilize your data, understand your data. You're not alone in interpreting all of this because we know it's so much information. So I really want to make sure that you feel empowered to use this data once you've had some time to sit with it. And that you have what you need. So if you do want more information, more specific to Westboro, please let Michaela know, and Michaela can put in a request to get you additional data that's more specific to you.
Thank you.
Are there any other questions?
I don't think so, but thank you so much. That was a great presentation. Lots of data, lots of hard work that went into it. I think the only limitation, speaking from Northborough, is that this data is from FY24. FY24 for Northborough was a really interesting year. So I think things, constantly change. And we saw that with the CART tool as well. So I think just looking at the data from that lens as well.
Most definitely. Thank you for bringing that up, Isabella. Again, this is a point in time capture, so we know so much has changed since the last fiscal year. But again, this is really not meant to say you have to make these specific changes from the data. You know your shared service arrangement best. You know your communities best. You know what has changed by now. So if you think there's another area you would like to prioritize and the data is not showing that, please prioritize that area. You know your community best. This is just a capture to show state legislature based off of this one time, this is what it looked like. But going forward, this can look completely different based off of your community's needs.
Do you know, and this might be totally jumping the gun, do you know if there are plans from the state to do this regularly?
I'm not sure if it will be exactly like this again, because this was truly a lot. But there is definitely in the SAFE 2.0 legislature a plan for annual reporting in some shape or form. So it really may not look like this again, and it may not look like the cart again, but it could look like a combination and something that we want to be low burden for local public health, because we definitely acknowledge this is a lot of data collection.
I'm glad it was acknowledged.
With the exception of this sort of initial process being a lot of work, I have actually heard, like in very broad terms, that the foundational public health services is kind of the fun part. Like that's the part that people love to do, and that's the part that, gets you, it's all the positive, like health fairs and social, all of the sort of good, nice feeling things that are sometimes it's you need to have that when you have all the other added pressures that are challenging. So just sort of taking a step back and offering that as you digest this.
And thank you, Jess, for that point as well, because the cart wasn't as much fun and it really focused on regulations and laws and things and requirements that need to be met. And a lot of folks during that time, I was also in local public health during that time, and I kept saying this is not representative of all of the amazing work local public health does. And so the FPHS was really attempting to capture more than just the requirements or just the performance standards in Massachusetts. And we hope we've done an honest job in trying to capture that for the first time in the state. And we know that there's so much more work to be done, but at the end of the day, local public health does so much work and deserves to be elevated to the point where they can continue to do even more excellent work. Mike, were you going to say something?
Yeah, I just follow up on what you were saying, what you and Jess were saying. The cart focused on the mandates, as the public health, local health system as it existed at that time. The things that we always have done and are expected to do. Now we're introducing, and SAFE 2.0 puts this into law, we're introducing the public health more broadly defined, local public health more broadly defined. And what we have in mind is a very gradual, incremental movement towards getting to the point where we can assure that everyone who lives and works in the Commonwealth has access to this broad range of public health services. And the other thing to keep in mind is that the expectation is not that the local health department is the entity that delivers all of those services, that has all those capabilities. The responsibility on the local health department is to confirm that they're there, but we'll also be talking to you in the coming months about building partnerships with the other organizations that are in your service area who also provide some of these services. And through whether it's formal arrangements like memorandum of understanding or just a new working relationship, will help you establish those contacts and confirm that the capabilities and the services are there. But it's not all on you. I guess that's the main point. It's not all on you.
Public health is a team sport, and I did not make that myself. That's not. I heard
You
that
didn't trademark that?
I did not trademark that. I've heard it from amazing epidemiologists across the state, but it's very true. Again, thank you so much for this amazing experience working with you all. I'm so grateful to have gotten to know you all a little bit better and to learn about the work that you are doing in such a truncated amount of time. And if anyone has any questions, please feel free to reach out to me directly or to Michaela, who will reach out to me. Thank you, everyone.
Thank you so much. So I guess just summarizing next steps. So we'll get the slides. Michaela will send them out to the group. Questions can either go through Michaela or Manize. And then Manize, are you available for like town meetings, or if we invite you to another Greater Boroughs meeting, would you be able to do that as well if we have
Yes.
questions?
Most definitely. That is what I'm here for. I think there's a formal pathway to request that through that TA request form.
Okay.
But honestly, you have my contact info. You can reach out to me.
Okay, perfect. And then we will all digest the information. Once we get the work plan, we'll also send that out to the group to kind of look at how can we match what we're seeing here. And then we will submit that. Jess, when is the work plan due again?
It's going to be like the third week in June.
Okay,
June 18th, I think.
perfect. So we have a meeting June 9th, I want to say. So we'll have time to kind of review and approve a budget and a work plan. So that all sounds good. Does anyone have any questions about next steps? All right, perfect.
It's been a pleasure meeting everyone. I
as well.
love working with Isabella and Michaela and love to see others as well. So thank you for your time.
Thank you.
Thank you.
So you're welcome to stay. We have a couple other agenda items, but and then perfect. Okay.
It's good. Thank you. for having us.
Thank you.
All right. Perfect. Well, thank you all. We'll pass it over to Michaela for the next agenda item. I have to find my agenda.
Yes, I think it's FY26 budget,
Okay.
which I can share the PowerPoint. Oh, hold on.
So as we talk about FY26 budgeting, we're kind of in a weird position where we still don't have the final deliberation, for lack of a better word, for the contact tracing funds. So again, it's really hard to make a decision when we don't know all of the information. So if we want to wait until June to finalize the budget, obviously we're not voting on the full budget, but if we want to wait to make any decisions, that's totally understandable as well, because we don't know if we have this large chunk of money that we could be using for staffing or the ClearPath contract or whatever it may be.
Yes. So, just this is from last time. This is the same information. Some of the expected spending is just updated for this year. Um, but after having time to digest, can definitely discuss these options. We can also, if it's helpful, like pull up the live budget spreadsheet and go line by line and kind of amend and edit if there was any in between options people wanted to see. But yeah, I wanted to kind of give the slide back up for reference after we've had some time to look at it and open it up for discussion. Also, did people get a chance to look over it, or do we want to like take some time to review what the different options are?
No, I looked over it.
Okay.
I am very interested in doing the nursing software for our nurses. I think being able to have the program where you can run reports is important. Um,
And I know Jim, did you have a preference on which one? Did Jim? I
yeah,
forget.
he had a preference. Actually, he thought he had one preference over the other, but I think the one he preferenced didn't run the reports.
Which is it I think I remember when we talked, it sounded like my Judah he liked a little more
Yeah,
because it
I
is a
think
little
we got that
more
one.
clinical. And I think both really have a reporting
Oh, we thought
capability.
one didn't.
I think my Juna does. It's just different from my senior center. And my senior center, the biggest difference is there's more of like you can communicate out through my senior center, like group emails and events with people that are registered, whereas my Juna doesn't necessarily have that specific capability. And the reports are a little different, but both kind of have that as an option.
And I also, I mean, I honestly like option number two. Because you're talking about hiring a new nurse and the salmon contract, correct?
Mm-hmm.
Yeah,
Yes.
so I think that that's beneficial because as you know, we're running the other programs that's the contract that they come out of, right? Is the extra nursing, well, that they would be coming out of?
Right. So right now, so the contract for Salmon VNA is 30 hours a week, and that is not increasing. So that is that 65,000 number. The rate that is increasing is per diem. It's going from $45 to $75. We currently use the per diem nurses for all of our CPR and AED trainings.
And I think it's important that we offer that as well.
Mm-hmm.
Mhm.
Right. So the goal would be to have this part-time nurse offer those trainings and webinars and seminars for the public at all of our community spaces, not paying that $75 hour per diem rate.
And then
I prefer that as well.
and then we would also be able to potentially ask them to do different programs as well, right?
Correct. Yeah. Like if Jim, I know Penny and Jim have been talking about like a falls clinic, like
Yeah.
it would be, I foresee or I see it as like a very much like health education programming
Yeah.
position because I think obviously Maven backup is important, but with Michaela being on all of the four towns, and Penny and Jim, I think we have a good balance. They're very communicative about, and you, Taylor, who's on, who's off, who has what cases. So I think we're good there.
Remind me, Penny is your staff or is she
She
part of the contract?
she's part of this. She's part of that
Well,
contract.
I guess that's where my concern is because Jim literally is just Westboro.
Yeah.
And he has been doing the fall clinics.
Okay.
So I don't mind them sharing and piggybacking, but I can't have them taken away from Westboro either.
Yeah, no, I totally agree. And Northborough doesn't have any nurse right now. So we
And I
will.
mean, I am trying to do some of it, but a lot of it I just don't have time to do anymore. So, like we
I
don't
think,
offer
yeah, I
any
think
program
adding
like
a nursing makes sense. for
Okay.
even Taylor.
So,
Is there a way, Isabella, just for flexibility, a way to like put it like up to 16 hours? Like, so some weeks, like if that person is only doing like 4 hours, that's fine. And then like some weeks they do the 16 hours. Like, is there a way to write it as something like that? That way there's flexibility in the budget.
I can talk to HR and town council. My only fear is that it won't be attractive if someone's not getting the certain hours each week, but
Well, maybe for someone who it's like a second job or like they're like a mom or something, like, on a busy week, they can work, 4, but on a week that we really need them, they can do the 16. I don't know, just a thought. That might be attractive to some people.
Mhm. Yeah, I can definitely ask. So the only thing that option 2 doesn't have is the ClearPath contract. However, if contact tracing comes back or there's other opportunities, we could look into that.
So we are getting rid of ClearPath.
Neither option right now has it in it, but I'm just looking at like the remaining amounts. There wouldn't be. Option 2 wouldn't have that. For sure.
So it's either nurse or ClearPath, basically.
Right. And I think with ClearPath, I think it's a great service, but right now there's only one Westboro and one Northboro case. I think it's a good chunk of money, and I don't know if we're getting the most, I don't know, service from it.
Can we still, this might be a question that's already been covered in the contracting process, but can we still refer people to them as an entity? We just can't cover it. So it's still a resource for community members, but not necessarily like for our staff.
Right. So
Make a
they're still like a
difference.
community organization. They do apply for grants. So depending on if they had grant funding, they could cover you or do like a subsidy. But those who can afford it, they can pay out of pocket as well.
Is there any way of making it an 8-hour nurse position and still having instead of a 16-hour?
We can play around with the numbers. I'm not sure on the top of my head if that would total, but possibly. Trying to do the math, but
Do you want to, I can pull up the budget if we want to see if that works.
8 times.
Can you see that? Is that still sharing? Or
It is still showing the Canva.
oh, 1 second. Reshare it.
Just I know that it's going to be a more utilized service. I just have not been able to fully introduce it to fire, police, and the senior center is already aware of it. But I know if, someone just contacted me about 3 further cases. So
Yeah.
And their capability is only 2 cases.
No, so right now they have 2 hours of opening. So each case right now is only taking 1 hour a week. So there is still room in their kind of our contract.
Okay, so he said adjust it to 8 hours. Oh, sorry.
Do you know how long each case typically goes for?
I don't know. I think it is
depending on the situation.
Right. I guess that, I mean, yeah, I don't know.
So if we also did, so if we added the salmon. Oh.
Michaela, you might just be able to do the total from Canva and just plug it into one of the categories so you don't have to go through each category.
Oh, the 27
Mhm.
or the like 25.
I just think it wouldn't be beneficial to, recently offer it and then now not. Do we have a breakdown of what each town is receiving for um, nursing services, inspectional services, things like that?
I do for inspectional services and nursing services now. I didn't include it in this meeting because we already had a packed agenda. But I can break that down as far as other services. I don't know if we track that. Or if there are other services you'd be interested in seeing.
I think would be beneficial for me is to see what each town is receiving in the grant and a breakdown of how.
Okay. In terms of like inspection, like nursing services, inspectional services.
And whatever else could be offered that I don't know what other towns are exactly have at the moment.
Yeah. I mean, I think that's most of direct services. I mean, the communications is always on the group level, website, social media. I mean, ClearPath is one that's more direct. That breakdown I don't necessarily have. And then like we could also look at trainings and who's registering for trainings and being able to support training for staff on that end as well. Okay,
I just really would not like to see that ClearPath is gone. Whether we go with a different agency, I don't know who else would offer it cheaper, or I don't know, but I just think that it's important to have that part of it.
So Michaela, so that number, so is that within budget for the 8-hour plus the 8,000 contract?
Yeah, so with the 8-hour, this
I
total,
think,
if you can see
did you add anything for training or is that part of that 25,000?
the training is part of the 25, but that's budgeted for what we budgeted originally for 2025. So this year we've spent roughly 14,000 on training and had budgeted like 3,000.
Yeah. So this year, because we hired Michaela late, we've been paying for every training that everyone wants. If we were to do this, like reduce 3,000 training budget, we would have to not do that.
Which I think is fine. For me, that'd be fine because I have it in my budget here
Okay.
for training and all that.
All right. So then it looks like that would fit and we would have what, like 12,000?
Sorry, this doesn't include if we
Oh.
do the nursing software.
Okay.
And actually, that's 38.
Okay.
So yeah, that would still allow us to do the nursing software as well.
So a little bit of both.
It's my preference.
Jen, this is Chelsea. Can you describe the support that you're getting from ClearPath now and how it's working out? We just haven't used them yet in Southborough.
So I'm sure you know hoarding situations. So they basically go all the time and set up goals for the homeowner or rental occupant on goals and how to eliminate items. As you know, it's a public health issue, and that's something that we're supposed to be doing, and we're not offering that. So I think it's important that we still do. I'm not, at least Westboro's not offering that. We don't have enough time to do so at all. I mean, it's such a huge task. And I mean, to tackle something like that, the hours spent usually is, 1 hour a week. I'm glad it's there. I still don't think it's not technically what is needed, but at least it's offering something.
So are you seeing progress with the cases that they're working on?
I have not followed up, honestly.
Yeah, and then
Okay.
for the one Northborough case, We can either refer or it can be self-referred. So that's all confidential. I actually don't know who is utilizing that service.
Oh, gotcha. So like a resident could go to them directly knowing that we have this service, but that would be, you would not know that.
Correct. I just get
Oh,
I just ask monthly, like how many cases per town. And if so, I talked, I think Lynn is her name. If someone were to call and they kind of do their screener and go over their financials, if they're able to like outright pay for it, they typically do that and they save our 4 hours for those that are in real need of that service. And then they prioritize
okay.
it based on the time they have.
Okay. So if like 6 Southborough residents called this week, um, they would prioritize based on what the borough's needs for that week. And if somebody could be self-pay, they would take them in addition to the 4 hours that that they did by priority.
Correct. That is my understanding. Yes.
Oh, okay. Oh, interesting. Okay. I would I think it makes sense, Jen, to do the breakdown like you suggested, between the 4 towns. And if we can somehow equate that to a dollar amount and leave out the items that like Michaela's time to run this meeting, like that's for all of us. So I don't think that needs to be in the analysis, but I do think it would be interesting to see the other services and if they're not equal and then how they add up over the course of a certain period of time.
Yeah, I think that's a worthwhile analysis, especially coming up on work planning and thinking about as we move forward. That's something I can work on putting together. Um, would you want that presented like at the next meeting, or do you think just each town receives a report? Like what would be best for you guys in terms of receiving that information?
Do you mean a report for all the towns and just send it to us for us to review, or do you mean, because I'm looking for a report on all towns, as
Mhm.
I'm sure Chelsea is. So I guess, I mean, I'm fine with you emailing it, and then if we feel like it needs to go on our agenda to discuss, then we can.
Yeah, I think looking at it from all 4 towns in one report, but just kind of so I know if if that needs to be a meeting agenda item, we can definitely add it, but the best way to think about that moving forward.
Yeah, I
And
think
Chelsea,
Michaela,
sorry.
whenever you're ready, just feel free to send it. And then if somebody requests to have it added, just make sure we give you ample time to include it on the June meeting.
Yeah. And Chelsea, you did mention the dollar amount. I think I was just assuming like a service breakdown of number of inspections per town. But are you wanting like staff time and equating that to cost as well in terms of dollar amounts?
If we can do rough, I think I think rough is fine if it's possible. Because I think what Jen's getting at is um what is each town getting out of the grant, and are we equitable in that allocation, even though we have different needs? Like, for
Mhm.
example, Westboro probably doesn't use inspectional services because they have inspectors, whereas Southborough, we do use it for food. So I'm guessing that's where Jen was going.
Yeah, we
But I don't want to
actually
speak for
are,
her.
yeah, no, see, that's something you didn't know. We actually are utilizing Michael. So I think it's just that we haven't, I don't want to say be transparent because we have all been transparent. I just don't think it's been an ask, and it's just something I'm interested in seeing for sure. And I'm
Yeah,
I'm more interested in the time than the cost, honestly.
fine. Okay. Okay. Yeah, I can uh cost I'm less certain on being able to exactly break that down. I think rough estimates are potentially possible, but time and kind of number of services we can look at. And I think, yeah, it's been transparent, but maybe not the visibility has been there to be able to see exactly how that's broken down. But I can work on that.
I think with the only caveat that the nursing is going to be hard because we want software to better track that. So I think that's just one limitation, but we can definitely talk to Penny about the different hours and services that she provides in each town.
Yeah. Yeah, I think right now we have a Microsoft form that she fills out each time she does a service and which town it was in. But that only started in November, so we can kind of talk about that.
Thank you.
Yeah.
So I think that's good for then the FY26 budget. We'll talk about that. You'll send it out. Hopefully we have confirmation about the contact tracing grant. And then yeah, we have 2 more months to spend down FY25. So keep sending ideas or items. I know Michaela has met with the nurses and has sent emails about inspection supplies. So any other supplies that you need, please feel free to send it. I know everyone's been training for this, so we've been paying those as they come. MHOA's conference, the early bird special should be coming out soon. Trying to think what else, Michaela.
Yeah, I can, sorry, I stopped
Did you talk
sharing
to
the-
Kristen about the clothing?
So there was an added allowable expense. It is only for PHE funded staff. So it would be Michael, Michaela, and I would have to check if contracted staff would fit in that.
Okay.
So I think we've covered, yeah, spend down. We still have everything. These are upcoming trainings. So if anybody's interested, I think you may already be aware of most of these, but just to have them all in one place. One other mention, OLRH is running a survey to get feedback from us as we interact with them. So this will also be sent out afterwards. You can follow this link. It's a quick survey. I took it in like 5 minutes, but it's a good chance to provide feedback. Also, I created my own surveys to get feedback on the biweekly infectious disease updates. As we go into tick and mosquito season, I'll kind of edit those, but would love to hear what's useful, what's not, timing, things like that, if you have any feedback. Fill out the survey if you have time. You can also just email me directly. And then just meeting minutes and future meetings, I think, is left, unless there's anything else before I move on. Okay. So approval of the meeting minutes from April 15th.
I move to approve the minutes from April 15th, 2025.
Seconded.
Second,
All those in favor? Westboro,
Yes.
Southboro,
Yep.
yes.
Northborough, yes. Okay, perfect. Those will be approved. Those are approved. We will send them to town clerk and they'll be posted on our website along with all of the other agenda and minutes.
Perfect. And then just our next meeting. So June 9th, we shifted it. And that's when we'll hopefully vote to approve the budget, because the budget and work plan are due June 19th. And we'll get those out to you before the actual meeting, so you have time to like digest the information and look it over. And that work plan, we'll also be looking at that at our next meeting. That's all I have, unless there's any other business.
Nope, I am all set. Thank you.
Awesome.
It's a good long meeting. But yeah, if you definitely will send out Manize's presentation, feel free to reach out to BME, Michaela, OLRH with any questions. I know it was a big lift. So any questions you have should be answered by them as well. All right, well, I will accept a motion to adjourn.
I make a motion to adjourn at 2:40.
Second.
Second,
All right, all those in favor, Westboro,
Aye.
Southboro,
Yep.
aye.
Borough, aye. Perfect. We